Mobile.
Okay, Bishwaroop, I think we can start now so that we have only 5 minutes left. So I think you can start your talk first, whatever.
Yeah. So a very good evening to everyone. Welcome you all to this wonderful session with the top faculties of the country. Mindray India is really proud to associate with Chhattisgarh Radiology Academy for this webinar on the most demanding topics of the year. We now hand over the session to Dr. Harshad Ruprela. Over to you, sir.
Yeah, first of all, good evening all. And I thank you all for, joining today with us. And before we start, I think we have 3-4 minutes still to go for 8 o'clock. Because as we have given time for 8, we'll actually begin from 8. So meanwhile, I think everybody knows everybody in the screen today, whatever we are seeing each other. We have today Patkar sir to begin with. He's going to give us, he's going to give a talk for 5 minutes and he's going to introduce the chapter. And I really need not introduce Patkar sir. He is already a very famous personality and he's known to all in the radiology group in India, and he's currently the president of IRA, National President IRA in radiology, and he's also the head of department of radiology in Nanavati Hospital. And there's so many things to talk about him, and I think the list is so big that I can't mention everything, but I'll just tell you I'll tell you the important things, his achievements. He's been given the Best Radiology Teacher Award in 2019. He has conducted many conferences, webinars over the last years, and I have been his student. He's been my guide, and I have worked with him for 2 years in Nanavati Hospital, Mumbai. And during that 2 years, we had so many, consultants, students coming into Nanavati Hospital for MRI training, especially for MRI training. And he's been conducting the MRI course, teaching course, I think, sir, since last 15 years or so. And it is always it always had a tremendous response every year. And many students practicing, even many consultants practicing MRI today have learned a lot of things from the MRI teaching course, which sir has conducted since last so many years. So I request sir to keep, pushing us and, encouraging us and even giving us the opportunity in the radiology platform so that, we can improve our practice and even our, reporting in day-to-day life. So all over to Patkar sir now. I request Patkar sir to, introduce our chapter now. Sir, all to you.
Thank you, Harshad, for the kind words. So everybody around, I think we know each other. Dear friends and members of IRI, it gives me immense pleasure to be addressing you through this virtual platform. I am thankful to the Chhattisgarh Radiology Academic team and their educational partners, Mindray, for having me on this platform. Though faced by a really unprecedented challenges due to COVID pandemic, the resilience, adaptability, and commitment shown by all the members of IRI, and we have almost 19,000 now, deserves a deep sense of gratitude and respect. I would like to thank our speakers for today, Dr. Anirudh Kohli and Dr. Chander Lulla, for sharing their knowledge and expertise on the topics that they're talking on. It is always a pleasure to be amongst such great radiologists and friends. I would also like to acknowledge the efforts of this activity, the organizing team, which includes Dr. Nitam, my friend for a long time, Dr. Harshad Ruparella, he has been my student, Dr. Sudhir Shukla, and Dr. Tushar Meher for their efforts in putting up this amazing session. This year has been completely different for all of us in every aspect. Our daily lives and professional life has completely changed. We've gone through lots of ups and downs, which we had never expected and probably will never experience. The main important thing is people devised new ways I think a lot of people are, you'll have to mute a lot of people. I'm all, people can hear me.
Yeah, you're audible.
All of us have devised a very new way of learning, changing our practice, adapting ourselves very quickly, and coming around the problem that we're facing. So we have updated our lives in spite of all these difficult times that we faced. We all have altered our way of living and working, but the drive to move ahead is what keeps us, all of us, going. At IRI, keeping in mind the importance of learning and teaching, we've conducted over 100 webinars as we talk now, covering almost all the topics related to almost all the subspecialties of radiology, whether it's cardiac imaging, head and neck imaging, musculoskeletal imaging, even artificial intelligence, entrepreneurship, etc. Evolving topics such as artificial intelligence, I thought would be less popular. We gave them a lot of importance, and the attendance for those topics, which were kind of offbeat, was also quite high. So this tells us how well read and how much hunger our radiologist friends have. As we took several phases and colors of lockdown and unlocking in life in our strides, we at IRI decided to fulfill our social obligations also. It was very, very tough time to conduct Raksha activities, but I got very, very good support from all the Raksha partners. I'm proud to declare that first of its kind All India launch of Raksha happened through virtual platform, and Om Birla ji, our Lok Sabha speaker, was there for the same. The program received a tremendous response countrywide, and as we talk now, almost 15,000 kits have been provided to needy girls across the country, starting from Jammu Kashmir to Kerala and even Andamans. So Raksha related gifts and essentials were provided to underprivileged girls and women of our society. Not only academic activities, but IRI also addressed a few other things that a lot of radiologists were suffering, the mental and physical issues for our members. And we started a novel concept called as Dear Zindagi, where we called trainers and psychologists to take care of our mental strengthening. An e-souvenir was launched by IRI and ICRI on International Day of Radiologists, a compilation of COVID stories by about 18 radiologists from across the country and who were working at the forefront of COVID situation. This was dedicated to radiology residents who were doing COVID duty, and this was our small way of showing our gratitude towards them. And this was very positively taken by a lot of people. We at IRI plan to conclude 2020 with the mega event called as Global Radiology Conclave 2020, which starts from tomorrow and will be on till Sunday. About 1,500 people have already registered. There will be 70 international speakers talking on about 80 chapters and lectures related to almost all the subspecialties with focus on neuro and musculoskeletal radiology. It is a case-based e-conference which will witness a galaxy of speakers from across the globe. Please do join us for the same. Also, you can visit IRI website for registration. I would like to thank you all for joining today's session, and I hope the new year brings with it a new sense of hope and belief for all of us. Activities like these will take the level of radiology in the country to next level, and young people like Harshad doing this is a real sense of achievement for me. We as radiologists are eye of medicine, and patients' well-being completely depends on us today. We have a lot of challenges like artificial intelligence, turf erosion, and we can do only one thing: keep updating ourselves and be better than the people who are trying to erode our turf. If we can do that, that is what will take us forward, and that's the way forward. So stay safe, take care, and all the best, Arshad and everybody else, for all these activities. Thank you all.
Thank you, sir. Thank you, sir, for the encouragement. And now I request Dr. Sudhir Shukla, sir, to introduce our first speaker, Dr. Anirudh Kohli, sir. Please unmute yourself, sir.
Arshad, can I log out?
Yes, sir.
Thank you all.
Thanks, sir. Thank you so much, sir, for the.
Thank you.
Sudhir.
Thank you so much. Dr. Anirudh Kohli and Dr. Chander Lulla do not need any introduction. They are well known. They are well known to entire fraternity, and they are very much associated with Chhattisgarh since very long, and is visited many times from years. But it is customary to introduce. So Dr. Ruth Koli did his graduation and post-graduation from Grant Medical College, Mumbai, Chief Radiologist, Bridge County Hospital Trust, Mumbai, and Consultant Jaslok Hospital, Mumbai, Editor-in-Chief, Indian Journal of Radiology and Imaging. Director of Indian Imaging Academy, a courses conducted by him in Goa. Very, very popular. Many of us attended those programs. Very informative and relaxing. With these brief introduction, I request Dr. Anirudh Kohli to deliver his talk. Dr. Anirudh Kohli, please.
Thank you. Good evening, everybody. It's a pleasure to be here. I'm just going to try and start getting my screen on. I need to go to share screen, Zoom. I'm struggling to get the share screen on. Is there somebody can help me?
Bishwarup, please can you help, sir?
So, can you just press on the share screen one?
Yeah, I've done share screen.
Okay.
And it says screen. And then it's asking screen broadcast. Sorry. Is my screen seen now?
No, sir.
Not yet, sir.
Not yet.
Okay, so I think I have a problem then, because I'm going to share screen. I'm on screen. It says everything on your screen, including notifications, will be recorded. Enable do not disturb to prevent unexpected notifications. So what do? Start broadcast?
Start broadcasting.
One second. Start broadcast?
Yeah.
Okay. Now, how do I get my...
Now it's seen, sir.
Now it's seen, but now I need to minimize it.
Yeah.
Okay. I got it. Now are you seeing it?
Yeah.
Yeah.
You're live, sir.
Yeah. Okay, great. Thank you. So basically, I think we were talking about something which is so topical. 9 months have gone by, and COVID-19, what really have we learned from an imaging perspective? And I think that's become very, very important today. So to first start off and understand the imaging, it's important to know the pathophysiology. Basically, the coronavirus has a characteristic spike proteins which have an affinity for ACE2 receptors. ACE2 receptors are in abundance in the alveolar epithelial cells, GI tract, heart, endothelium, kidney, but the lungs are the most vulnerable due to a large surface area, as well as these act as a reservoir for viral replication. After gaining entry into the cell, replication occurs, triggering apoptosis, release of inflammatory cytokines, and basically there's an exudation into the alveolar space with associated diffuse alveolar damage. And that's really what we see on imaging, that diffuse alveolar damage and the exudation, because they appear like ground glass densities. Now, this diffuse alveolar damage, which is the basic pathophysiology, evolves over 1 to 3 weeks, and it progresses through these 3 stages. And understanding these 3 stages is very important to understanding the imaging appearances. In stage 1, which is an exudative phase, which usually is for about 4 to 5 days from the onset of the illness, there is a limited leakage of fluid into the interstitium. Therefore, imaging is usually negative. And that's why early on, chest X-rays and CTs may be negative. In the stage 2, which is the inflammatory stage that goes from day 4-5 to day 9-13, there is an alveolar leak of protein, fluid resulting in a diffuse alveolar opacities, predominantly in the lung periphery. And that's one important point, that the coronavirus tends to extend right to the periphery of the lung. And that's why we see pathological changes predominantly in the periphery of the lung. So you see ground glass densities in the periphery of the lung. And then with increasing exudation, these ground glass densities may become consolidation. And of course, if it further progresses, you may end up with whiteout lungs or ARDS. Important in this stage, that's 2, is what are the differential diagnoses? What are the other conditions which can look like this? Hypersensory pneumonitis, pneumocystis carinii, alveolar hemorrhage, chronic eosinophilic pneumonia, NSIP, organizing pneumonia, any form of acute lung injury, and very important is pulmonary edema. And this becomes an important differential when we do CT for COVID, because both patients are breathless, often their saturations are down. And the way we really differentiate is by looking for septal lines, effusions, cardiomegaly, which is what we'll see in cardiogenic edema and not in COVID. The ground glass densities that you would see with pulmonary edema are basically central, whereas in COVID you see peripheral opacities. And as I said, it goes through 3 stages. The 3rd stage is a reparative phase, which is the fibroproliferative phase, where there's proliferation of epithelial cells and fibroblasts with collagen deposition. And this actually manifests on imaging as a transition of alveolar opacities to interstitial. And really the interstitial opacities that we see are organizing pneumonia. So from the alveolitis ground glass densities, things convert and becoming organizing pneumonia. And this organizing pneumonia clears with time. Sometimes it takes months. Occasionally, it leaves behind a telltale scar in the form of a residual subpleural curvilinear line. And finally, the imaging returns to normal. Though occasionally we see very few, as compared to what is being reported in media and literature, very few cases end up with a residual subpleural fibrosis or cystic changes. So the CT chest is very sensitive to detecting alveolitis, which is what we know from our previous experience with viral pneumonias, basically H1N1 and other influenza-based pneumonias. CT chest has been found to having a very high sensitivity because it is sensitive to demonstration of alveolitis in COVID, with anything ranging from 90 to 97% sensitivity. An important point which we'll allude to later is that asymptomatic patients can show positive CT findings, so we'll cover that later. The problem that is being portrayed for CT today is actually its specificity. Its specificity is lower because naturally its appearances can overlap other appearances. And we'll handle this as we go along. An important point to remember is that the CT may be positive before the RT-PCR is positive, and we've seen that in many, many cases. The CT may be positive when the RT-PCR is negative, and that's a very, very important point. Like asymptomatics may have positive CT findings. Of course, you can have a negative CT with a positive RT-PCR, and that is why it's very important that you need to have both a CT as well as RT-PCR. So what are the basic CT features that we see? As I already told you, that basically what you're going to see ground glass because of the exudation. As the exudation increases, you can have consolidation. So you can have a mixed appearance of ground glass and consolidation. Where is the location of the abnormality? Typically subpleural, peribronchovascular. Posterior and basal, as I also said, the virus extends out to the periphery. Those are more commonly involved. And usually the involvements are multilobar and bilateral. You may see different types of appearances have been described earlier in literature, but really they're not important, which is the halo sign, which is basically a ground glass around a consolidation, atoll sign, which is consolidation around the ground glass area, vacuolar, where there's clearing of the ground glasses. But the important 2 signs that we look for are, one is the prominent vessel sign. And this is a very important sign basically that there is inflammation of the vessels in the areas of involvement. So within the ground glass densities, you will see prominent vessels. And that has become a relatively specific sign in COVID pneumonia. And of course, as I mentioned, as things clear, you may see a subpleural curvilinear fibrosis. So this is typically what you would see in, this is typically what you would see in COVID. One minute. This is typically what you would see is areas of ground glass densities, especially in a subpleural location. And here also you can see changes, and notice every time you can see that the vessels are prominent. And as you look more and more at that, you will see, but this is the typical ground glass in a posterior subpleural location. Here a more extensive involvement, and that's the basic key. You see ground glass bilateral, often in a multilobal location, and very often extending to the subpleural region. You could get even central ground glass densities, which are more dense, and here there's ground glass, you can see the vessels through it. Here it's more dense, you can't see the vessel, there's a consolidation. And so areas, multifocal involvement, predominantly subpleural, but also you can get them peribronchovascular. And occasionally you may see changes only peribronchovascular. Again, just showing you different cases where you can see the extent of involvement. And one thing that is quite described often is that within the ground glass, you may get a septal thickening known as a crazy paving appearance. And this is part of the whole process of inflammation where the lymphatics get thickened, inflamed, prominent, and that's how you get these appearances. But the key is to demonstrating ground glass densities, especially in a subpleural location. And this is a subpleural curvilinear line because this is a resolving COVID pneumonia. And this sometimes will be a telltale sign that you would see. I'll just show you a few videos. Sorry. I'll just show you a few videos of as scanning from the top to the bottom. And as you can see that there's quite a bit of ground glass extensive involvement. And this patient is going into ARDS because they're dense posterior consolidations with air bronchograms. And this is the reason why the patient will be extremely hypoxic. And because typically in ARDS, the involvement is in the posterior portions of the lung. And that is why they tend to put these patients prone to ventilate them better. Here's another one where you can see that the epices and upper zones are relatively clear. But as we go down, you can see that there's subtle areas of, it's very sensitive. There's subtle areas of ground glass density seen, especially in the lung bases and the subpleural regions. And of course, bilaterally. Here's another case. Again, just to show you the appearances that you have in COVID. They can be very subtle, but as you scan down, this has more of consolidations and denser consolidations. This is a fairly typical what we see, where you see these peripheral subpleural ground glass densities in the periphery and sparing the central parts of the lung. And with time, as these will evolve, as I said, and become consolidations, organizing pneumonia, and then I will show you follow-up of cases. So one thing that has been used a lot has been when you're reporting the CTs after seeing it has been the CORADs. Now, CORADs is very questionable, especially in areas where there's a low prevalence of COVID. That may be useful because it's classified into 6 categories. CORAD 0, when the scan is not interpretable, where it's maybe a lot of motion artifacts. CORADs 1, where it is something which is not infectious, so maybe a lung tumor, emphysema, ILD. CORADs 2, where the level of suspicion is low, and where basically there's an infective focus, but they're typical for infection, like if you see tree and bud appearance, conglomerative centrilobular nodules of infectious bronchiolitis, or you see a lobar pneumonia, or you see a lung abscess. CORADs 3 is where you see ground glass densities, but it may be compatible with other diseases like, say, hypersensitivity pneumonitis, small airway disease, or typically pulmonary edema. CORADs 4, 5 are basically ground glass densities, which are CORADs 4, they say maybe unilateral, maybe peribronchovascular, but CORADs 5, where they're typically peripheral. But in our opinion, when you have a high density of involvement, anything from CORADs 3 to 5 is very, very suggestive, unless you have typical appearances of pulmonary edema, very suggestive of COVID. Also, why CORADs is not really of great utility, because you could have somebody with CORAD 0, 1, or 2 who also could have RT-PCR positivity. So it's become questionable. We do use it, but it's really of questionable value. Here, for example, if you have an appearance like this, where you have, where you have typically centrilobular conglomerative nodules, this is infectious bronchiolitis and not suggestive of COVID pneumonia. And here where you see typical septal thickening, ground glass densities, again, pulmonary edema. So basically, here I'll show you the follow-up of cases, and this is very important because as I'll show you is that you can see that the peripheral areas are ground glass on the initial scan. Here, there's a more little denser consolidation. But as time progresses, that ground glass converts into what people are calling fibrosis. But this is actually all organizing pneumonia, and I'll show you why. Again, here that there was involvement and it evolves. So the first CT, if it is done within the first 5 or 7 days, will not show you the peak. The peak is between 9 and 13 days. And that is when you'll see the extent. This is just to show you follow-up of lesions out here, and then followed up, everything is cleared up. Subpleural consolidations, everything is cleared up. Here is a very nice example to show you one case of how things progressed. It started off with this of ground glass densities, typically in the subpleural location, some consolidations here, ground glass densities here. And how did it progress by day 11, which would be the peak of involvement? You can see that ground glass has got converted to consolidations. And some of these consolidations have already started to clear up, but there's a lot of peribronchial changes, there's architectural distortion, and possibly what people would call fibrosis happening. But fibrosis is irreversible. And this is a follow-up at day 45, where you can see these consolidations have cleared, and now they've gone back to being ground glass densities. And then subsequently, you can see everything is cleared up. So if you end up calling this fibrosis, you're wrong, because you can see that clears up. So this is all an organizing pneumonia that goes on. Here's another example where you see the ground glass densities out here, septal thickening out here, and then things reduce. But again, you can see it's a consolidative process out here. And then you can see everything clears up with time. Here is an important one where the first CT is negative. And that is very important. You can have a normal CT and follow it up after 5 to 8 days and start to see subtle but definite involvement of COVID pneumonia. And of course, then everything is okay. Here's another case to show you initially ground glass density, subpleural location, anteriorly, a bit peribronchovascular, and then it progresses with more consolidations happening. So scans evolve. After 6 days, you can see there's an evolution. And then subsequently, you can see all these lesions have cleared up, and they clear up with time. Here's another one, initial scan, which shows you ground glass and consolidations in a subpleural location. It progresses after a few days, and you can see dense consolidation. So that's at the peak. And then subsequently, you can see things are clearing up. An important point in this case that I'd like to show again is a normal scan to start with. Then you see the ground glass changes. And very important, you see this subpleural curvilinear line out here. And here you can see it's gone. So this subpleural curvilinear line, which we call as fibrosis, is also a misnomer because it's probably organizing pneumonia, which will clear up with time. This is one case which has been a problem. Started off with diffuse peripheral ground glass densities, these converted to consolidation, and then finally we do have fibrosis. So a rare case that we have where you see subpleural interstitial thickening. We're still following her up after nearly about 5 or 6 months and hoping these things will start to clear up. And that's where we need to be careful when we see cases like this where there's consolidation, and then you see traction bronchiectasis, you see architectural distortion, you see subpleural changes, peribronchovascular changes, whether these patients should get an antifibrotic drug, which may help to resolve these inflammatory changes, or it's just steroids and long long-term use of steroids, which will help clear up things. Here you can see quite extensive changes. Initially ground glass consolidation, but extensive changes. It progresses within 4 days, quite a bit, quite dramatically. This whole area, which was clear, has got now involved. And then you can see by day 15, things are clearing up, and followed up after 3 months, everything is gone. Everything. The lungs are back to normal. The other thing, so this is basically telling you of the diagnostic part of CT. Now, what about prognostication? How can we help in management? And for that, we have something useful known as CT Severity Index, where imaging may be utilized as a surrogate to determine the extent of disease burden. Low percentage of aerated lung correlates with a poor prognosis. So if we are able to determine what is the extent of lung involvement, especially in a pandemic, where due to sheer volume of cases, the extent of pulmonary involvement, along with clinical parameters and inflammatory markers, can be used to triage patients for better and more appropriate utilization of healthcare. Because there's so many patients, limited beds, limited ventilators, limited facilities, if we can decide, that will be of great value. So basically the severity of lung involvement can be assessed by visual methods. Could we get that person to mute, please? Thank you. The severity of lung involvement can be assessed by visual methods or a software that determines the percentage of affected lung volume using AI. The disadvantage of the visual method is that there is inter as well as intra-observer errors because it's a subjective method, and there is significant over or underestimation of the extent of involvement, and it's very time consuming. So we believe only in using the deep learning automated algorithms, because at times we are doing 100 scans a day. So it's impossible to provide a CT severity index then, whereas you need the machine to pump it out. There are multiple CT severity indexes. There's a 20-point scale, there's a 25-point scale, there's a 40-point scale, there's a 72-point scale, and then there's also a deep learning total percentage of involvement. The main popular ones are the 20 and 25 point scales, and these are based upon the 5 lobes in the lung, and either in the 20-point scale, you divide it into 4 points each lobe, where it can be from 1 to 25%, 26 to 50, 51 to 75, 76 to 100. And in the 25-point scale, what you do is you break up 1 to 25% into 2 categories, as a result of which you move by 5 more points because 5 lobes to a total CT severity score of 25. But as you can see with this, it's very, very difficult subjectively to say whether 25% is involved or 35% is involved. So should it be 1 point or it should be 2 points? And even then, you can see just adding up these points, if somebody has 50% involvement in all 3 lobes and somebody has a 75% involvement in all in 3 lobes, the numbers will change and the percentage will be different. So it's very subjective and very questionable, which is why we believe of course, we use these points, but we believe in a total percentage of lung involvement, because after all, that is what CT severity is to tell us, how much of aerated lung is available to breathe. And this is just to show you how the automated program occurs. It automatically picks up the areas of ground glass densities. It gives us into a lot of detail about it. Finally ends up giving us right on top in the total opacity score. This is on a 20 scale. It gives us the percentage of opacity. So it automatically does this, spins it out in 2 minutes to us, and of course gives a lot of detail on each lung, both lungs, on the volume, the opacities, and the HU values, but that's not important. And you get a graphic representation like this, which is also very useful. So you can see this is a series where you have early small involvement, little more involvement, peripheral involvement, some central involvement, more extensive involvement, and going to totally white out lungs to the ARDS. So it becomes a very useful representation and a communication tool. And that's one thing that has been talked about. Why did CORADS come? CORADS came because it needed to be, you need to have some communication tool. When you're doing 100 CTs a day, a clinician is also probably seeing 100 cases or 50 cases a day. So for him to go through all the details becomes difficult. Whereas if he gets a visual idea like this, he knows and he can triage the patient to decide what to do. And because of that, we also did a study where we looked, basic thing in COVID is oxygen. Does the patient require oxygen? Doesn't he require oxygen? And if he requires oxygen, does he require low flow or high flow oxygen? Or does he require non-invasive ventilation? Or does he require mechanical intubation? So we looked at all this. We did these studies, nearly about 950 cases, with using the 20-point scale, the 25-point scale, and percentage in all three. And what we found, first thing is that 20, 25, and percentage are comparable. So you can use any three of them. They're good. But percentage was a little better, but not a dramatic difference. So that's one important point that came out, that use any scale that you're comfortable with, 20, 25, or percentage. And this is what happened, is that when we looked at this, what we found is that the mild category, which is people with room air, we were able to prognosticate that if they had a CT severity index on the 20 scale between 0 and 4, they would go into room air category, and that's what happened. If it was 5 to 9, they would require low or high flow oxygen. And if it were above 20, they would need NIV or intubation. There's a very small percentage which overlaps in these, but by and large, the percentage was very high. In the 25 score, it was 0 to 7, 7 to 14, and above 15 would require NIV or intubation. And this is what happened with percentage 0 to 10, 10 to 30, and 30%. And this is really a very useful method to prognosticate. Of course, the caveat is if you scan too early, you may not have all the changes seen. But the important thing is that all these programs pick it up, whether it's ground glass or consolidation. Why? Because ground glass, when it evolves, will become consolidation. So what you need to know is the extent of involvement, how much is aerated lung. And that is why most of the results, even based on one scan, are very, very accurate. The last point that I want to cover, and probably the most important point, we have a pandemic which has gone on 9 months. Why? What is it wrong that we have done in this pandemic? And what do we need to learn from this pandemic? What we know is that the key to containment is to detect individuals who are positive for SARS-CoV-2. They've got the virus, isolate them to prevent any further spread of the virus. And the gold standard to detect is RT-PCR. But RT-PCR has a high false negative rate of 30 to 40% due to sampling, transportation, processing errors. This can be corrected in highly dedicated labs. But COVID is a global pandemic, so you can't ensure quality across the globe. It may be negative in low viral loads, and it has a small window of positivity. Very poor sensitivity before day 5, and very poor sensitivity post day 7. So really, it's day 5 to 7 where you're going to get good results with an RT-PCR. And we know RT-PCR has a long turnaround time, 24 to 48 hours. By the time the result comes, RT-PCR positive, that person has met so many people and passed the virus on. So this is basically the issues of RT-PCR, issue of false negative or delayed RT-PCR results. Undetected individuals are infectious and will transmit them. What we needed was an accurate, quick test to isolate individuals promptly. They tried the antigen test, but the antigen test is only 30% positive, much worse than the RT-PCR. Can we use clinical evaluation? And a lot of guidelines have talked about clinical presentation. If they're moderate symptoms, severe symptoms, okay, RT-PCR is negative, do imaging. But the most important thing about COVID is the clinical presentation is non-specific, and most important, 70% of patients are asymptomatic or who have mild symptoms, so which you will not recognize as COVID. Of course, symptoms like fever, fatigue, myalgia, sore throat, dry or productive cough, diarrhea, headache, anosmia, hyposmia, we know. So those are very specific. But what about 70%? They are asymptomatic. And I think one of the issues is that very early in the pandemic, we got a lot of guidelines. We got guidelines from different organizations. And the guideline accepted by most was the American College of Radiology recommendation, where they were very right. They said the key goals in response to COVID-19 outbreak are to reduce morbidity and mortality, minimize disease transmission, protect healthcare personnel, and preserve healthcare system functioning. Very right. Viral testing, they said, remains the only specific method of diagnosis. Confirmation with viral test is required, even if radiological findings are suggestive of COVID-19. They are missing the fact that 30 to 40% is false negative. Then they go on to say, generally the findings on chest imaging in COVID-19 are not specific and overlap with other infections, including influenza, H1N1, SARS, and MERS. But where is influenza? Where is H1N1? Where is SARS? Where is MERS? They're not there. And being in the midst of a current flu season, but where's the flu season? It's summer with a much higher prevalence of influenza in US than COVID-19. Limits. This is most surprising. COVID-19 is less than influenza. Totally wrong. Issues related to infection control in healthcare facilities, including the use of imaging equipment. These measures to eliminate contamination for subsequent patients may reduce access to imaging suites. So basically they were saying they are worried about healthcare workers getting infected. And second, they're saying that if you start using CT for COVID, then what about the other patients? Other patients won't get access. So then finally they concluded CT should not be used to screen for or as a first-line test to diagnose COVID-19. CT should be used sparingly and reserved for hospitalized symptomatic patients with specific clinical indications for CT. An appropriate infection control procedure should be followed, of course. They also add that most of the radiological data comes from China. Some studies suggest that chest CT in particular may be positive in the setting of a negative test. We want to emphasize that knowledge of this new condition is rapidly evolving and not all of the published and publicly available information is complete or up to date. This was published on March 11th, 2020, when the United States had only seen 1,000 coronavirus cases across the entire country. Based on that, they made this. They said that most of the information comes from China. If you read all the Chinese articles, what did they do? They used CT and RT-PCR. Then, of course, you have the Fleshner Society, which said, again, imaging is not indicated. Patients suspected of having coronavirus disease, mild clinical features, unless they are at risk for disease progression. So it's only indicated if somebody has a worsening respiratory status. They're ignoring 70% of people who are asymptomatic. They say, of course, in a resource-constrained environment, if you don't have RT-PCR, you can do imaging, but only if they have moderate or severe symptoms. Same thing happened with WHO, which said for asymptomatic contacts of patients with COVID-19, WHO suggests not using chest imaging for the diagnosis of COVID-19. Same thing happened with the Royal College of Radiology, okay? And then we all have ignored important studies which came out right in the beginning. And this was in January, where there was a famous cruise ship, Diamond Princess, where everybody got COVID on it and it was stuck outside the coast of Japan. 54% of the asymptomatic patients demonstrated pneumonia on CT. And there are studies which have shown 10, 15%. There are studies which have shown 60% of asymptomatics have positive CT findings. The point is, as soon as you're letting out people who have a positive COVID pneumonia, have a positive with SARS-CoV-2, they are there to spread it out. We've had controversies even in Mumbai or in India, where there have been radiologists who have fought with each other, saying whether CT chest should be used or not be used at all. But the key is again another article, the asymptomatic transmission in New England Journal of Medicine. Asymptomatic transmission is the Achilles heel of current strategies to control COVID-19, where they accept that COVID-19 cannot be controlled unless you catch the asymptomatics. So in a nutshell, all these guidelines said, don't use CT. Why? It has a low specificity. It can look like other things. Advocacy of CT may overwhelm existing resources, so reduce access to non-COVID patients to imaging suites. CT may act as a potential disease transmitter via surface contamination, especially exposure to imaging department staff, and it utilizes ionizing radiation, something that's thrown at us every time another field doesn't want us to move forward, whether it be coronary CT angio or whatever be it. But you have to understand that we are in a pandemic. And in a pandemic, it is sensitivity which is important and not specificity because of the sheer numbers. Another important point is we've seen it over the last 9 months that diseases have disappeared in this pandemic. Of course, we know surface decontamination and how to protect our staff. And of course, we can reduce radiation by using lower kV, modulating the tube current, increasing the size thickness, increasing the pitch, and ending up with low kV CTs. The other thing is, we did a study where we looked at volumes. What we found, where we looked at a public hospital and a private hospital combined, in pre-lockdown, lockdown, unlock phases, what did we find? That there was a marked drop in volumes during lockdown. There was no respite in unlock 1 and 2, and some recovery in unlock happened for X-ray and CT, basically because they were being scanned for COVID. So you can see marked drop in volumes. So the diseases just evaporated. So there was no question of overwhelming the resources. There's no question of non-COVID getting access to imaging. We in fact went further and looked at just emergency imaging, acute fractures, whether people were scared to come to hospitals, whether it was because there was no public transport. What was the reason? So we looked at emergency situations where you can't avoid going to the hospital, like acute fractures, stroke, acute abdomen, or a coronary angio required. And here again, you could see all these volumes from pre-lockdown dropped. Emergency procedures also dropped. So there is no question of overwhelming the resources. So really, I'll conclude by just saying that these two articles, Asymptomatic Transmission, the Achilles heel of current strategies control 19, the Diamond Princess, and you will see soon a lot of articles coming out, because we in India have had access to CT, we've had access, and then lots of papers coming out on how much asymptomatic patients have a positive CT, and that's in this range of 50 to 60%. So always, to make a diagnosis, you require a systemic approach, and especially in areas with high prevalence, very important to identify suspicious cases, to isolate them. CT, of course, very important to make the diagnosis. Second, for triage, to decide based on the severity of the involvement, whether they should be home quarantine, whether they should go to COVID centers, whether they need to go to hospital, and in hospital, whether they should go to a high dependency unit or an ICU, and all that information is available if you do your CT scoring, and that helps guide treatment. And of course, follow them up. You can assess the treatment response, and especially when you have organizing pneumonia, whether you need immunosuppressives like corticosteroids, or you need to use fibrotic, anti-fibrotic agents, which gives prognostication. And finally, I close with a very important statement. And I feel as we look back over these 9 months and all the information that I've shown you and the thousands of cases that we have done, is I think the utilization of CT scan may just be one of the missing keys in closing this pandemic. If we had caught the asymptomatics, the positive asymptomatics on CT, it would have been actually cheaper to put small CT scanners out, 6 slice, 2 slice CT scanners out in the field, rather than creating these big corona centers. It would not cost anything compared to the economic hardship that we have faced and we are going to face. And I think the biggest disservice done to us has been these guidelines, which have been based on no facts. As I said, ACR put out their guidelines March 11th when they had only seen 1,000 cases, and everybody followed that. And as we look back over 9 months, I think that is one of the biggest mistakes. Thank you. I hope we have new fashion as one benefit coming out of coronavirus. Thank you very much. I'm happy to take questions now.
So it was an excellent lecture and very informative. We've got to know so many new points, and I would like to ask you, sir, a few questions. Many of our viewers have put up some questions, so I'll just ask them one by one, sir. The first question is by Dr. Rajiv Pal. What is the protocol for follow-up CT? Which day we should advise the first CT, and how frequent, or in follow-up, how frequently and when to get a CT scan done in a COVID patient? That is the first question, sir. Second is, you had showed a very good diagrammatic representative of COVID CT patient, where you have this colored images showing clearly the amount of lung involvement. So is this already, this software is, and even the software calculating the percentage of lung involvement? So we are using basically the score. Many people are using 20, 25 or even 40 scoring system, and they have different ways. Since in a busy city department, many are overscoring or underscoring, and since scoring is related to prognosis, so I feel personally that the percentage, the software calculating the percentage of lung involvement is a better and a faster way of assessing the prognosis. So is it a inbuilt software or we need to buy it? That is another question, sir. And so these two questions first, I would like you to answer.
Yeah, okay, thanks. So basically, I'll take the second question first. Is basically, I think this is very important to have an automated software. So we did even a study where we asked the residents to, score it. And it was crazy that there was so much of underscoring and overscoring because it's impossible to assess, how much. So an automated thing is the way to go. There are a lot of automated ones available. There's 3D Slicer, which is available online, and that's free. It's slightly cumbersome, but it's better than doing subjective. It's faster than doing subjective. Okay, so 3D Slicer is available free. Secondly, that there are a lot of new softwares which have come up where they are charging you 50 rupees or less per scan, where it sucks your data in and gives you everything, the diagrammatic representation, the lung percentage, everything. And I think 50 rupees is not a large amount, and I'm sure that they'll come down on price. Third is that certain companies like Siemens and all have now developed their own software known as CT pneumonia. So one, talk to your vendor, ask him whether he has a software, whether he can get you a software. Two, if you're willing to spend 50 rupees, then you have a lot of these people available. And third, if you want to do it free, do 3D Slicer. But I agree with you, don't do subjective. And as I said, do 20, do 25, do percentage, because we studied it across 950 patients and they all work well with different goalposts. Okay. Coming back to your first question, which is about when to do a CT. Of course, I won't go back to the point about diagnosis, but basically in the follow-up of the CTs, that if you have a first CT which is negative, okay, and the person starts to develop symptoms, okay, you should repeat the CT within 4 to 5 days, because that will give you at the peak where is the involvement. And ideally, there is between 9 and 13 days. Secondly, if there are further worsening symptoms, repeat the CT again after about 4 to 5 days. If the symptoms are regressing and patient is improving, inflammatory markers, D-dimer, CRP, IL-6 are not going up, don't worry, move on. And when your last CT has shown organizing pneumonia or extensive changes, or this patient has been through the ICU, then you need to follow up the patient. And then we would do a follow-up CT at about 1 month. And then based on what we see, we would do a follow-up CT every 2 months after that, not more frequent than that. Okay. And we have people that we are following till 6 months. The whole issue is that we believe a lot of those changes, which are called fibrosis, are actually organizing pneumonia, and with time they disappear. So it's very important not to call it fibrosis.
Okay, sir. So one more question before Dr. Sudhir sir takes up the question round. Sir, what is the CT finding when we? What are the CT findings when we try to add the fibrotic drugs, anti-fibrotic drugs, or to the patient's treatment? What are the CT findings? I think you had mentioned, but I just need you to repeat those things, if just to revise it again.
Sorry.
What are the CT findings? So what are the CT findings which will help us, the clinician, to add on certain anti-fibrotic drugs, in the patient's treatment?
Yeah. So basically, if you're having subpleural changes, and subpleural where they're looking like fibrotic changes, where you're seeing some amount of architectural distortion, you're seeing traction bronchiectasis. So the fact traction bronchiectasis would be because possibly a fibrotic element. But of course, we do see traction bronchiectasis with organizing pneumonia also. Okay. So now it's really the point about steroids is proven. The point about antifibrotic agents is not proven. So if you are seeing subpleural changes, architectural distortion, then there is a definite role to try antifibrotic agents.
Thank you, sir. Dr. Sudhir, sir, please, if you have any questions.
Yeah, sir, what is the difference between a pediatric and adult patient in HRCT finding in COVID-19?
So I think that is one of the fortunate things. We hardly see any pediatric involvement in COVID-19.
Yeah.
So yes, and
Involvement
even
is
if
less.
they do have, they're very, very mild. And the ones that do have it show similar changes. So no real difference. And that's one thing that we see in COVID-19. It's like you walk in, this is COVID, this is COVID.
And what is the significance of a reverse halo sign? Is this specify anything or just a finding?
No. So reverse halo sign, vacuolar sign, these were
Organizing
all signs
pneumonia.
which are described initially, and these are basically evolving features. So when you have the, halo sign, it's basically that the ground glass is clearing in the periphery of the consolidation. Vacuolar sign, the ground glass is clearing in the center of the lesion. Etoile sign is when the consolidation is along the periphery of it. So it's just features of evolution. In the initial days, they were given a lot of importance. Crazy paving was also given a lot of importance. But honestly, they have no management and no impact on management.
Yes. What are the findings, sir, if you have a comorbidity, COVID and associated with some other disease, comorbidity is there, like tuberculosis, diabetes, cardiac and renal failure?
So basically the comorbidities of hypertension and diabetes are the ones which have been looked at quite a bit. And the CT severity scores does go up in these, but not in all or not in a large percentage. It's very difficult to predict in COVID that who is going to have a higher CT severity score and who's going to have a lower. We do see hypertensives, we see diabetics, and some of them have very low CT severity scores. And some people who have no comorbidities and have higher severity. But by and large, the hypertensives and diabetics, if you look, have a slightly higher CT severity score. And those are the ones you want to scan a little more often.
Sir, is there any correlation of clinical, pathological and HRCT finding in the mild, moderate and severe cases?
Yeah. So basically, we looked at the parameters like IL-6, D-dimer, all the lab parameters. And what did we find? That there is a very poor correlation between lab parameters and imaging. Where there is a great correlation is imaging and the oxygen requirement, which will naturally reflect on the PO2. Okay, so there's a very, very good correlation between CT extent of involvement and clinical in the form of oxygen requirement. And I think that is a key to COVID is oxygen requirement. None of the drugs have really worked.
Sir, is there any CT finding which can predict cytokine storm in COVID-19 patients? Is there any CT findings, or it's impossible to predict who's going to undergo a cytokine storm?
No.
Okay. So one more question: if the patient, if there's a
honestly, if I just would like to step in, it's like cytokine storm again was something which was in the initial days. Okay. And now we don't see that much of the utilization of cytokine storm because it's basically a progression to ARDS.
Okay. So it's a misnomer basically.
Yeah, and that's why Toxilumab and IL-6 now is, that whole therapeutic angle is gone.
Okay, sir. And so one more question: what if there is a upper lobe involvement, just a single upper lobe, say right or left, subpleural ground glass opacity, RT-PCR negative, patient has mild fever and cough, no other symptoms, should we begin with COVID-19 treatment, or how to go about this patient? There's no lower lobe involvement.
Absolutely, we are in a pandemic.
Okay.
Everything
so we
is
need to assume that
is unless proven otherwise. Point number one. And second, if you want to do it, have a repeat RT-PCR done.
Okay.
This same issue happened with a senior minister in Delhi. RT-PCR negative and CT was positive in an atypical way. And it was only pressure that we said that, look, this COVID. They said, "Nahi." And you know how Delhi has a VIP syndrome. And then fortunately, they listened and repeated the RT-PCR and it was positive.
Okay.
So,
And HRCT is very useful in emergency situation also, sir, when we have no time for RT-PCR and all those cases. Sir.
Of course.
We have to
I think that,
and all that.
Yeah, I mean, we've seen so much of, the French have come out with a study now where they have looked at all their hospitals across And the conclusion of that is that wherever CT and RT-PCR was used, they were able to control disease. It's out in radiology. And I think that's really where I think the mistake was. We should have used CT more and used CT as a screening tool. And it would have been so much cheaper to have so many CT machines around and so easy to report, connect packs. And anyway, this is looking back now.
So there's one
सिटी
more
का
question.
प्राइस भी बढ़ा है सर अभी सिटी सेल भी बढ़ा है काफी दे पीपल से कि लॉट मेनी सिटीज आर बीन सोल्ड आउट
Yes, maybe more should have been.
So there's one more question from the viewer. How to differentiate pulmonary edema from COVID changes? Dr. AK has asked this question.
Yeah, I showed exactly an image and I had covered it in one slide because that's very important, because clinically they can look the same. Patient is breathless, patient has a low oxygen saturation. So basically you see pleural effusions. That's something you don't see in COVID. Okay, so you see bilateral pleural effusions, important point. You will see ground glass in both, but the ground glass, you'll see central and pulmonary edema. In COVID, there'll be peripheral. And most important, look for septal thickening, which is the slide that I showed you. And these three findings really help us in differentiating.
Okay, very nice. I think, Sudhir sir, any more questions to ask before we conclude?
I think it's
So this was wonderful, and I think it was more than what we expected actually, and many things, and it was very, very nice and informative brief. And I don't think so any questions left to be answered. So thank you very much, and we look forward to more and more academic sessions from you.
Absolutely.
we really enjoyed your talk, sir. Very informative
very,
and
very good,
engaging.
Thank you.
Thank you so much, sir. Thank you so much.
Thank you, Dr. Kohli. Thank you.
Thank you, sir.
Thank you very
you,
much.
sir.
Bye-bye. Stay safe.
Same to
Bye,
you.
thank
Thank you. Okay, Bishwarup, we can proceed with the Mindray thing now.
Okay. Thank you, Dr. Kohli, again for the wonderful lecture.
Thank you.
Request Dr. Rajiv Virmani, our National Clinical Marketing Head, to take over the Mindray Technology session.
Thank you. So, am I audible, Vishwarup?
Yeah.
Am I audible now?
Yeah, you're audible.
So, good evening, everyone. It was really an insightful session. Dr. Anirudh, if you can hear me out, so I am really, really happy to be part of that session. It was really an education. I loved the session, the way it went, sir. And, you concluded it with the prognosis, the treatment. Everything was so much clear now, that the way you have advocated the use of CT, it's really, really very insightful, sir. Really thankful to you for that.
Thank you.
And the last audience that was missing in your slide was the residents. They can answer the full question now on the CT use of CT in the COVID screening. It was
well, I didn't cover X-ray, which is huge role.
Yeah. So the question was
protection.
like use of CT in the COVID screening and the
use in the periphery, sir. Use in the periphery, where the HRCT is not. CT is not.
It was wonderful session, sir. Loved it.
Thank you.
Wonderful. Great. So many congratulations to the organizers, Dr. Netam, Dr. Ruparela, Dr. Sudhir, and Dr. Tushar, and the entire Chhattisgarh Radiology Academy. It was a wonderful session. Now, actually, we were all mesmerized with this session. Now to go towards the ultrasound of things. So we need to have a little bit of transition. So let's change your gears a little bit. And we would like to just showcase you a little bit about the platform or a technology you can call, or simply put a solution that Mindray has with a goal of providing high efficiency with precision imaging to what Dr. Patkar was saying as the eyes of the medicine or the radiologist community. So which is one of the most valuable branches that we have in clinical medicine. So we would like to showcase one of the platforms, will not take much of the time. It's a platform, it's called X Insight. Most of you are already familiar. Vishwarup, can you just help me with the video, please? Yeah, will not take much time before Dr. Chander Lulla comes and starts his session. Good evening, sir. Yeah, Vishwarup. Thank you, everyone. Enjoy next session as well. Thank you so much. Yeah.
I'll hand over the session again to Dr. Harshad Ruprela. Yeah, over to you.
Welcome, Dr. Chander, sir. Very nice to see you. Looking fresh always, sir.
Thank you.
So many of us are really excited to know, what is new in this. What are the new findings in ultrasound in high-risk pregnancies, and especially in sudden fetal demise, which we always see. Many of our gynecologists are always asking us that you did a Doppler 1 week back and you told everything is fine, and now suddenly there's no movement, and you come up with this diagnosis of sudden fetal demise. So why, what happened wrong suddenly? Everything was normal last week, and so we have no actually answered, what to tell them. And I think today, by your talk, I think many things are going to be clear. And before Dr. Chander sir begins his talk, I would like Dr. Nitam sir to introduce Chander sir. Nitam sir, can you please unmute? And
Harshad, thanks for giving me such opportunity. Next topic is newer advances in ultrasound in high-risk pregnancy, role of umbilical vein and fetal heart. That will be delivered by Dr. Chander Lulla sir. He is consultant sonologist and fetal medicine specialist. Currently, he is holding the post of head of USG department in Jaslok Hospital, Mumbai, consultant USG department in Reliance HN Hospital, Mumbai, consultant RIA Clinic, Mumbai. He has published books and lot of papers in Indian and international journal. And there are a lot of awards and achievements achieved by him. Few of them are ex-president IFUMB, ex-councillor AFSUMB, ex-editor IFUMB journal, and ex-ISUOG ambassador for India. Currently, Dean IFUMB. So, Sir Chander Lulla, sir.
Thank you, Dr.
Please.
Netam. Thank you, Dr. Harshad. I'll just share my screen.
Yes, sir.
Okay, so you just heard a wonderful talk on the topic of the day, that is the COVID. So let's de-stress you a bit, and let's move on to certain new exciting developments in ultrasound. And as Harshad said, we do have a lot of problem with sudden stillbirths. And as you know that India is the stillbirth capital of the world. We have a very high stillbirth rate. And we are always looking at ways to reduce our stillbirth rate and new technologies. And that's where I decided to focus on new things which can stimulate us to do further research on these subjects and also look into day-to-day practice. Now, this study was actually done about 3 or 4 years back, and it came into focus only when recently, I think Dr. Abu Ahmed spoke on this same subject in the Fetal Medicine Foundation forum. And so as you know, the placenta is the central organ of perfusion between the mother and the fetus, and then there is diffusion changes that happen in the fetus, and you have oxygenated blood coming from the umbilical vein into the fetus and via the placenta. So it's but logical that these two elements, which have not been studied here too, should have some more focus. And I am sure that in the future, we'll have more work on this. And already there are a lot of papers being published on the placenta and umbilical vein. As you know, in FGR and most high-risk pregnancies, there is inadequate transformation of the trophoblastic tissue into a low-resistance circuit. And therefore, we get in many of these placentas, when they are studied histologically, there's a lot of infarction, inflammation, there could be vasculitis, fibrosis, and these are usually seen on pathological studies. So this was an attempt to see whether we can see these changes antenatally, and usually these will result in inefficient oxygen delivery to the fetus. Now, you have seen over the years, the placenta looks so different in different situations. You've got a very healthy looking placenta here. You've got a very poorly looking placenta in the middle here with a lot of lacunae, a lot of intervillous thrombi. There's a placenta with a lot of calcification. This is, of course, adherent placenta, and this is a chorioangioma. So there are a lot of varied appearances, and surely these may correspond to some of these tissues like hard tissues and soft tissues, and therefore they may show differences in elasticity. And that's when we started looking at placental fibroscan, the basic principle being same, that the transducer is used to make a push pulse, which creates a shear wave, and then a receiving pulse of the transducer measures the shear wave, and we get the shear wave speed, and the speed is faster in stiffer tissues, and we have seen that happening in the liver very well. So we decided to do this in the placenta, and we studied a lot of normal placentas, and we studied a lot of abnormal placentas in an attempt to see whether the placentas differ in normal pregnancies and in pregnancies with PIH and FGR, and to calculate the various sensitivity, specificity, predictive values and negative predictive values, and which area of the placenta is essentially useful. So we did about 60 cases. And we looked at 30 PIH and FGR and 13 normal. We looked at all the various parameters, multi-vessel Doppler, RV, and Leica imaging. And you can see that in the 30 cases with PIH, we had 19 of them had FGR, and 11 of them were well-sized. And these were some of the results, and you can see that a lot of them had high systolic and diastolic blood pressure. The mean uterine artery Dopplers were high in many of them. And then finally, when we looked at the values of the velocity measurements, we could see that at the cord insertion, we were getting the highest mean values of 1.9. And the intermediate zone between the cord insertion and the periphery, it was 1.7. And in the periphery, it was 1.8. So these were very, very high values. And then we tried to normalize these values so that we get at least a sensitivity of 80 to 90%, and using statistics. And we found that the ideal cutoff was about at least 1.42 as a mean value to get a sensitivity of 90% and a specificity of 83%. And these were, of course, varying at the intermediate zone. So the highest values were obtained at the cord insertion site. So this is, of course, just a normal pregnancy. They're showing the point shear wave where the values were taken from different areas of the placenta. And you can see that's a normal placenta, and that is 1.37 meters per second. So if you have elastography techniques, you should try it, and it seems to be working. May not work all the time, but fairly good in about 80 to 90% of the cases. And here you have a fetus where you can see that the values are pretty high, 2.51 meters per second. And another fetus with absent end diastolic flow with growth restriction, and you've got a value of 2.6 meters per second. So we said, let's look at normal tissues. And here you can see that the placenta is anterior, and this is a large subchorionic hematoma, and you can see that you have values as low as 0.59, 0.5. So definitely soft tissues are giving lower values, and that is what we established. And then there are a few papers which are coming up. Now, all these papers will have different cutoffs, and depending on what you take as the sensitive value. And in this particular paper, they took about 1.9 meters per second, and versus 1.3 as normal. So so different cutoffs. A cutoff we have taken is about 1.4 to 1.5, and anything above 1.4 indicates a possibility that this placenta could be more stiff and may land up with FGR and plaque rim shear. So with any new modality, there are a lot of questions, and there are a lot of people questioning it. And it remains to be seen over the years how these modalities perform. And I'm sure once you start looking at it, we have an extra tool which may help us predict. Now, when you look at stillbirths, it's important to see that a large percentage of IUFDs don't actually occur in growth-restricted fetuses. They actually occur in normally grown fetuses at term or in the the later part of pregnancy. So here, actually, a well-sized baby is really undergoing stillbirth. Now, if you see even the incidence of cerebral palsy, for example, it is occurring in fetuses whose weight is more than 10 centiles. So obviously, this all points to a subset group of stillbirth patients who are well-sized, but who have something that is going wrong. This paper highlighted the fact that even 1/4 of normally grown babies or averagely grown fetuses have placental histological abnormalities corroborated with chronic placental insufficiency. And we ourselves had an experience, as you can see in this patient, 36, and as you must have all seen, sudden fetal death. Now, this was a 36-week fetus with good diastolic flow, good MCA flow, good uterine flow, absolutely normal ductus venosus. Because it's a high-risk pregnancy, and we kept monitoring on a weekly basis. It was an infertile patient. And just exactly 1 week later, you see that the diastolic flow, the umbilical artery is markedly less. The LICA is normal, placenta looks good, and you have even poor cerebral circulation. And look at the ductus venosus. It's showing extreme high pulsatility. And this is just in 1 week. So obviously, there are some changes occurring which we could not understand. And that's when we started looking at the umbilical vein Doppler. That's what got me interested into looking at umbilical vein, because obviously there are some parameters which are not being answered with the MCA, umbilical artery, and ductus venosus Doppler that we are seeing. So reduction in umbilical vein flow occurs weeks before IUGR actually sets in. And this was actually told to us as early as 1984 by Gill et al. And it's only now that we are trying to focus on it and see. And in many of these fetuses, there are no significant changes in the umbilical artery Doppler. And we know that now with late onset FGR, umbilical artery Doppler is really of no use. It's the CP ratio and the MCA and the uterine artery Doppler. So reduced placental blood flow may represent an early event in pathogenesis of IUGR. And then we had this another interesting paper published by a group called Rizzo et al. And they looked at the Doppler in the late onset fetal growth restriction, and they found that Doppler usually precedes the late onset changes by 2 weeks, and usually it was CPR and MCA, which was more reflective of fetal hypoxia, and that we all know is CPR is very useful. But these changes occur later in the stages of growth restriction, and probably that's maybe the reason why we may lose some of these babies, because early Dopplers may be normal. And so when they looked at the Z-scores and the area under the curve for adverse perinatal outcome, they saw that umbilical vein blood flow normalized either to the fetal weight or the abdomen circumference was faring slightly better than the CPR and the uterine artery PI. So that stands to reason that we should look at these parameters more carefully. So umbilical vein blood flow normalized to either the AC or the fetal weight. And we normally normalize it to the fetal weight because it's much simpler. Abdomen circumference can have variation. So fetal weight is a much easier value. And this is the formula which is used to calculate, just like you calculate blood flow in any other vessel, depending on the mean flow and the mean average peak flow and the diameter of the vessel. Now, if you see the volume of blood flow, which is normalized per minute per kg of the fetus, it's actually going down or remaining plateauing between 37 and 42 weeks. So there is a decrease in placental perfusion as the fetus approaches term. And any event which may reduce the cardiac output may put this fetus to a very high susceptible situation to fetal death. So, and the placenta therefore will have a low placental reserve, and the oxygen deprivation at this stage will cause sudden fetal death. So we have some normal values also published in 2005, as early as 2005 in prenatal diagnosis of the 50th centile of the umbilical vein blood flow, which you can use. And when we did further research, we found that in some papers, they have actually come with some cutoffs, which of course we need to verify in our own studies, and we are doing that. And we found that the cutoff for adverse perinatal outcome, if at all we have to take one figure, is somewhere between 60 and 70 ml per minute per kg. And what they found was that IUGR fetuses died before 26 weeks and below 600 grams if the blood flow was as low as 50 ml per minute per kg. And versus the viable IUGR fetuses, which had a higher umbilical vein volume flow. Normally grown fetuses, of course, range to about 130 ml per minute per kg. So we said, let's look at that. And this is a fetus growing on the 5th centile. The cerebral circulation looks okay, but the umbilical artery is showing high resistance, and the CP ratio is low, because of which it's 0.73. That's the technique here. You're measuring the diameter, you're looking at the mean averaged velocity, and from the formula, we get a volume flow of 91 cc's per minute. So this is not normalized to the fetal weight. And following weeks, as you see, the fetal umbilical artery shows reversal of flow, uterine artery shows increased resistance. And when we looked at the volume flow, it was as low as 30 ml per minute. And if you normalize it, this was about a 900 kg baby weight, a 900 grams baby weight. So if you normalize, it was yet very, very low, 34 ml per kg. And we know that even Doppler shows that here these fetuses are fetuses at high risk. So I think it stands to reason that umbilical vein can be a good parameter. And if you see, this is a late onset fetus, I mean, a 3rd trimester fetus, which is averagely grown, normal growth on the 50th centile. The CP ratio has come down to about 0.87. The blood flow is normalized to the fetal weight is 52 ml per kg per minute. And look at the ductus venosus, it's already showing high pulsatility, indicating that there is a possibility of early onset cardiac strain. So of course, we must not wait, even though the umbilical artery Doppler is normal, the Leica is normal, and the placenta looks reasonably good. I think it's time to intervene. And here is another fetus, which with absolutely normal Leica, normal placenta, normal MCA, but the CP ratio is 1. There were multiple loops of cord around the neck, and their mother reported loss of fetal movements. And again, we see blood flow is 54 ml per kg per minute. And fortunately, we could remove the baby and save these fetuses. So I think these two parameters are pretty good. And of course, time will tell, but even now you can use it in certain specific situations without actually making your decisions on these isolated findings, but as a collective measure. When you're looking at the fetus with multivessel Doppler and ultrasound, you can put the gynecologist on guard if you're seeing a very low umbilical vein volume flow, provided you're measuring it correctly with proper angle correction. Now, angle correction is very, very important, as you know, with Doppler techniques. So you even with umbilical vein flow, you need to have a proper angle correction. Now, the third not so well focused on area is the fetal heart. And we have seen a lot of changes either with M mode, with TAPSE, with Doppler, looking at fetal cardiac function and the inflow, the outflow, systolic and diastolic function. So we said, let's look at a new Doppler parameter, because many of these parameters tell us either about systolic function, diastolic function, and some like MPI can also give information of global cardiac function, but they're all Doppler based. So you have to rely on good fetal position and good Doppler angle correction. This again, we chanced upon, as with the other cases, was looking at this fetus at about 33 weeks, and with cardiomegaly with fetal growth restriction. And as we were playing with tissue Doppler imaging, we saw that this segment of the heart was not showing tissue Doppler signals. And you can take a comparative similar view fetus with the apex upwards, and you can see that there is global Doppler, tissue Doppler changes. So we said, what is wrong with here? There is, of course, cardiomegaly. And since we had speckle tracking from 2010, we put the speckle on the fetal endocardium or in the fetal heart. and we could see that the red spot on the left lateral wall of the myocardium, which was not contracting with tissue Doppler, did not show a contractility. It was showing a flat curve as compared to the blue on the septum. So we realized that here speckle tracking seems to be a good modality, and we started seeing this in the year 2010. You track the endocardium, and you can see that the endocardium moves and the vectors show the magnitude and direction of the contractility. So our first paper we published in 2018 on speckle tracking in normal and abnormal cases. But here I'm just showing you the normal values, and we looked at strain. Strain basically is just like elastography. It is the difference in the myocardial length between systole and diastole. So what exactly it is telling us that usually the myocardium contracts by about 20%. With a range between 10 and 20%, the lowest being 10%. So when it contracts, we give it a negative value, so it is a negative strain. And there are other parameters. We also looked at ejection fraction, which ranged from 35 to 75%. So we looked at normal, which was, as I said earlier, 10 to 20, and you can see minus 22. And we looked at a lot of abnormal cases where we got as low strain values as minus 6. And then comes HQ with GE, and we have all seen that HQ is much simpler than the earlier technology we were using, VVI, with Siemens, and I think now most companies will be having speckle tracking, including Mindray and other companies. So with this technology today, you can not only look at cardiac function in each ventricle, but you can also look at global cardiac function. And one of the easiest things to do is measure the global sphericity index. And as you know, the fetal heart becomes more globular when you have fetal growth restriction. So you don't really need even speckle tracking, but you just measure the transverse diameter at the annular valve and the apical to base diameter in the interventricular septum, and this over this is usually less than 1.1 because usually our heart is oval, and when there is volume overload or pressure overload, the heart enlarges and becomes globular, and there is a change in shape. But this, instead of being subjective, is now done very easily with speckle tracking. So we looked at IUGR, we looked at various conditions. There is pleural effusion hydrops, there is ductal constriction. We looked at cardiac function in the left and right ventricle. And we came up with values which we have already published. But you see, in most of these conditions, the strain was low, below minus 20%. And we looked at ejection fraction, which was also low in some conditions where the myocardium is affected. If the myocardium is not irreversibly affected, then the fractional area change and the ejection fraction is yet maintained. So let's look at some IUGR cases. Now here you have a fetus which is reasonably well grown on the 50th centile. CP ratio is this is 33 weeks with LMP growth of 34.6 weeks. And we can see that the CP ratio is less than 1. There is right ventricular enlargement. And when we do the speckle tracking, you can see that we got values of global strain of minus 10% in the left ventricle, and you can measure it in all the 24 segments of the heart. And right ventricle was as low as minus 5.6. So obviously the right ventricle is affected more than the left ventricle because it's the systemic ventricle in the heart, fetal heart, and bears the brunt more. So even the fractional area shortening or contractility was lower in the right ventricle. And then you follow it up at 35 weeks, exactly 1 week later, and you can see that the Doppler changes are also showing poor increased resistance. Fetal weight is on the 5th centile. And now there is worsening of the Doppler parameters, and you've got the parameters worsening to minus 3.8% global strain and 3% in the right ventricle. So obviously we need to remove the baby. And this is another fetus, 38 weeks, prior scans normal, abdomen circumference measuring below 5th centile. You can see the Dopplers are normal, but look at the myocardium. It's very thick. The mother had diabetes, and there's kind of cardiomyopathy developing here. and we have global strain as low as -6%. So very obviously, this is a very, very important tool where we can study the fetal heart more objectively, and we can take some decisions. So again, there are very limited criteria that is available, except now Gregory DeVore has published a large number of papers on this subject, and I recommend that you should go through it, because I'm sure again in the future we'll be looking at the fetal heart more importantly. Now, when he looked at perinatal death, what he found was the left ventricle, as I said earlier, is the last to get affected. And it holds on the fetal circulation to a longer time. But when the left ventricle diameter increases beyond the 95th centile, then you have a higher incidence of perinatal death. Similarly, if the left ventricle ejection fraction falls, as you can see below the first centile, or -5.6 z-score, then you have a higher incidence of perinatal death. And also the fractional shortening in the left ventricle. So the left ventricle is the last, it's like our, ductus venosus. So we don't really wait till then. If you've got changes in the right ventricle, then it's probably the time to act at that point of time. And this is just a single ventricle. You can see a single AV valve functioning, and you see the myocardium is thick, and you can see that the strain in this heart is quite affected. You have a global strain of only 2.9%, and that's quite understandable, because the whole load of this fetus or circulation is on this single ventricle. So that is as far as cardiac changes go. And then just like to round up with two interesting situations. This was recently a fetus. Of course, this is a posterior urethral valve with severe oligohydramnios. Until now, we were treating these fetuses with bladder shunts. And we all know that there are a lot of problems. The fetus dislodges the shunt. And by putting in a shunt, we don't improve the fetal bladder function. We only improve the fetal renal function to some degree. And most of these fetuses over the years require a fetal transplant and have not done well. So the obvious issue is to treat the posterior urethra. And with my good friend Vivek Krishnan and our pediatric surgeons at our hospital, we had this fetus with a hugely dilated posterior urethral valve, 22 weeks, severe oligohydramnios. You can see there's almost no liquor, and we did fetal cystoscopic repair with mentoring by Dr. Vivek. And you can see this is the fetoscope going in, and with laser, we could fulgurate the valves. These were the valves that we saw. And again, that's laser, and we could fulgurate the valves with the help of the pediatric surgeons. And this is a post-op picture. You can see that the bladder has now collapsed. It is thick-walled, but we have restored the function, because you can see that the liquor has improved. So this is one of the therapeutic procedures which I think is going to have a lot of future, because we have a lot of high-risk pregnancies who want to continue the pregnancies and who want to make an attempt to cure these situations. Finally, a little word or two about the aortic isthmus. That is, as you know, the three-vessel trachea view, and you can see that the aortic isthmus is the area where the transverse aortic arch joins the ductus, and we have normal flow patterns which change with fetal growth restriction. You have reversal of flow, and that indicates that the right ventricular circulation or deoxygenated blood is going to the fetal cerebral circulation via the aortic isthmus. And these fetuses can have poor neurodevelopmental outcome. So we saw a group of IUGR fetuses, 10 of which had aortic isthmus reversal, and we could see that the Doppler changes associated with adverse perinatal outcome in about 30% of a large group of these patients, we were seeing changes in the aortic isthmus. And these were sometimes changes which antedated the changes in the ductus venosus. So you can see this is a whole group of 80% of fetuses where the aortic isthmus antedated changes in the ductus venosus. So we said, let's look at it. But of course, this is it's a bit tricky because the vessel is difficult to image at times, and there are a lot of pitfalls which I shall discuss. But what's important is that you can predict poor neurological outcome at least a week before you see venous Doppler changes in the ductus venosus. And that's one of the fetuses. You can see absent end diastolic flow, MCH showing normal flow, but you have marked reversal of flow in the aortic isthmus. So that's the time probably to counsel the parents that we may be dealing with long-term neurological sequelae. And that's another one here, fifth centile, reversal of flow in the aortic isthmus. Now, there are some false positives which can set in, and one of them being, of course, if you have a cardiac abnormality, you can see here that if you have a hypoplastic heart, it doesn't work because then there is stealing of blood flow to the cerebral circulation and you have reversal of flow in the aortic isthmus. This is also another situation where the fetus had IUGR with reversal of flow in the umbilical artery. But here the aorta was marginally smaller and the left ventricle, as you can see, was marginally smaller than the right ventricle. So something like a tubular hypoplasia of the aorta, and this also showed reversal of flow in the aortic isthmus. And therefore, you have to be very careful that you rule out. This is the aorta, which looks smaller, and you can see that there is reversal of flow in the aorta, the ductal-based reversal of flow, suggesting a ductal dependent circulation. So this is not actually reversal in the aortic isthmus. This is reversal due to the fact that there is a hypoplastic tubular aorta, and which is causing this reversal. So since there are a lot of false positives, you have to use this vessel with great care. And then if you have ruled out cardiac abnormalities and other abnormalities, even a vein of Galen can cause stealing of flow and cause reversal, for example, then it's probably a good modality which tells us that these fetuses can have long-term neurological sequelae. And finally, I would like to conclude with a couple of slides, is just to open our mind to the etiology of IUGR. And as you see here, if you look into the etiology, 40% are due to placental causes or placental insufficiency. 40% of small fetuses can be constitutionally small, but 20% can be chromosomally small. So you have to actually be very careful when you do your ultrasound to rule out a genetic abnormality. And you can see it's not only the major aneuploidies that lead to growth restriction, but today there is a vast spectrum of conditions with at any age. You can see that the trisomies are usually seen after the age of 35, but we have a host of other genetic abnormalities which can be also seen in the younger age group. This is, of course, typical trisomy 18. You can see there's a strawberry-shaped head with cardiac changes, hand changes, and of course, growth restriction. But what really caught my attention was this fetus, which came to us after birth, actually, for the second pregnancy. And when I went into the past history, I saw that the earlier fetus had a symmetric IUGR with Dopplers were normal. Fetal weight was only 1.35 kg. And when they actually did a microarray of this fetus, of this child at birth, there was a major deletion abnormality. So stands to reason that sometimes when we have changes which are not following the regular pattern, for example, if there's IUGR with polyhydramnios, or there is symmetrical severe IUGR, we must look at genetic parameters very, very closely. And also not only the regular karyotyping, but we have to look for the microarray and the clinical exome, because as you can see here, that almost in 6% of IUGR fetuses, CNVs were detected, which with normal karyotypes, and these were pathogenic for those particular situations. And you have a vast number of papers, as you can see, which have been now published, which tell us that the microarray and the clinical exome are providing us more insight into genetic causes of fetal growth restriction. And you can see that over and above a normal karyotype, in about 5 to 15% of cases, newer modalities can help us. For example, here, this is a fetus with cardiac abnormality, something like a Fallot's. with no thymus seen, with the cleft palate, and this is a 22q11 microdeletion, and this fetus had growth restriction. This fetus came to us at growth restriction at about 24 weeks, symmetric growth restriction, and you can see that all the long bones were short, and there was something funny about the whole fetus. There was a slight nasal bridge depression, a slight upturning of the fetal nose, and when we did a clinical exam, lo and behold, we found an abnormality which we had not seen earlier. This was a 3M syndrome, and when we did the parental karyotype, both the parents were carriers. And then if you go and see in literature, you have a lot of these conditions like the Russell-Silver syndrome and many other syndromes which can cause similar growth restriction. And of course, one of them being Noonan's, and this is another fetus we had with persistent nuchal edema and typical facial features of low set ears, again, upturned nose, widened forehead, and growth restriction, and it was a case of Noonan syndrome. So the message here is that keep your eyes open. For ultrasound is of prime importance, and you can see here 33 non-consanguineous the fetus at 35 weeks. It came to us with microcephaly, short long bones, facial dysmorphia, extensive periventricular calcification. You can see there are fractures seen in the bones. The bones are short, and look at the facial dysmorphology on 3D. And when we actually went into the clinical exam, we found a very, very rare autosomal recessive syndrome, which fitted with all the phenotypic findings. And this was osteopetrosis, osteosclerotic bone dysplasia called the Rain syndrome. And this is the fetus at birth. So in conclusion, we have a lot of situations where placental abnormalities can lead to oxygen deficiency in the fetuses. And we have some new tools, and I suggest that we start using these tools, something like FibroScan, and we can even use microvascular imaging now that is possible. And we know that FGR is a functional disorder, and Doppler is central to the diagnosis and management of FGR. But the first step is identification, of course. Then we look at timing of intervention and avoidance of morbidity and mortality. And that's where new vessels, maybe cardiac evaluation and even genetic evaluation will add to the scope of the management of these fetuses. So I thank you for this opportunity, and I hope you have some messages to take home. And if there are any questions, would love to interact.
Thank you so much, sir, for this exclusive lecture. I think most of the part of your lecture was so new. There were so many new things to learn, and you know, we really actually need to put so much of effort to catch up the new things, you know, which you have told in this lecture. The umbilical vein, the fibroscan of the placenta, the myocardium strain, the size, shape of the heart, and you know, even to look for other causes of IUGR, especially the chromosomal things, you know, happening. So I think this whole concept of you know, prediction of you know, sudden fetal demise using all these parameters, new parameters, is so new to all of us. I think most of us, I think we have not, if you have heard, we are not practicing. And even I think the values which you have told, I've forgotten now. I need to ask you again. So just, can you just briefly summarize?
Okay, so 20% is the figure that you should remember.
Okay.
As I told you, the myocardium contracts by 20%.
Okay.
So if you have 8 and 10 centimeters, 22 is the difference.
Okay.
And ejection fraction, we have been seeing 35 to 75. But we go more by now by the strain, we go more by fractional area shortening, which is about 35%. And we go by diameters, which have published values. And I suggest we all read Gregory DeBoer's papers, because he has already established also a lot of normal values.
Okay, sir. Very nice. So one more thing. Now I would request Dr. Tushar and Dr. Nitam to put forward some questions. Dr. Tushar, please go ahead if there are any questions from the audience. Unmute yourself, Tushar, please. Your thing on your, yeah.
Hello. Thank you, Dr. Chander Lulla, sir, for giving us a complete new insight to look for the FGR babies, because all these are completely new things for all of us, because we are not practicing as Harshad told us also told that most of us not knowing us also and not practicing also. So like ARFI application in placenta for fibrous scan and roll of umbilical vein. Though we are doing umbilical vein, but we are not used to do it or more. We're used to do more like MCA, umbilical artery, uterine artery, and Doctor's venosus. So thank you for giving complete new insight to this topic of sudden fetal demise. So my first question will be for assessing umbilical vein Doppler, which will be the most perfect site? Is this the intra-abdominal portion of umbilical vein or the extra-abdominal portion? And what will be the sample volume? And what is the exact angle? And what is the appropriate technique to assess the umbilical vein Doppler?
Yeah, so that's actually the most important part of this lecture, and I'm thankful that you asked it. It's exactly the same way, like I said, you measure volumes with, like in the portal vein or any other vessel. You look at the mean averaged velocity, and you look at the diameter of the vessel. Now, which part of the vessel to take? If you have a good view, you should take so that the angle is 0 to 30 degrees, because as you know, Doppler is angle dependent, and the best values can be obtained between 0 and 30 degrees. So if you have the umbilical cord insertion site at the fetal abdomen, that is where it enters the liver, then that is a good site because you have clear-cut margins that you can measure as the diameter. So umbilical vein in the fetal abdomen can be used. If not, then we just take any vertical segment of the cord wherever we have a vertical segment and you have a low 0 to 30 degrees angle in the umbilical vein, you zoom it up, zoom up the image so that you can measure the diameters very accurately. As you know, volume has a little problem. You need to be very accurate about the diameters that you measure. And when you place the Doppler, there should be proper angle correction. And you should take, you try not to get the artery in the vein. So if you use the abdominal portion of the umbilical vein, it's much better because you don't get the umbilical artery contamination in that specimen.
Okay.
Thank you for the nice description, sir.
So one more question by Dr. Saket Jain. He's asking how to calculate umbilical vein volume, umbilical vein flow volume. So I think it comes automatically in
the... it's in all the machines you have volume flow calculation available. It's a very complex physical calculation. I don't understand it myself. I just use the volume flow on the machine.
Which comes automatically, I guess.
Comes automatically.
So after this volume flow which has come, we need to divide it by the
fetal weight. So suppose you have 100 ml per minute.
Okay.
If the fetal weight is say something like 1 kg, then it is 100 ml per minute per kg. If it's 900 grams, then you divide by 0.9.
0.9. Okay. So what is the cutoff? What is less and what is normal?
So the cutoff, as I said, I showed you the values at various gestation age. There is a 2005 publication in Prenatal Diagnosis, but a rough cutoff is about 60 to 70 ml per minute per kg.
Per kg weight, 60. Okay,
60 to 70.
So if 60. It is less than 60, then
we must.
What do we write in the report, sir? Suppose if we have calculated the umbilical vein, everything is normal.
So now here I must warn you, there are no guidelines for this. There is no. There are some published papers which have mentioned the criteria, but these are not in the Barcelona algorithm or the. So you can use it for your own reference, and you can manage the prayer. You can mention the umbilical vein volume flow on that you have measured it, and you can, on a personal basis, with other Doppler parameters and other situations, like if you have fetal movements which are less, or if you've got a 37, 38 week fetus, high risk pregnancy, then you can communicate this information to the gynecologist that we are looking at low volume flow. But there are no published criteria that you must deliver these babies with a volume flow. So this is just to help you as a tool, and it's helping me. But of course, I'm sure there will be a lot of papers, and in the future, you see, it's just like when we started doing Doppler in 1991. People said, what is the use of Doppler? We have DSA and we have biophysical profile, and today you can't do without Doppler. So I'm just predicting the future here.
Okay.
But there are established criteria which you can use.
Okay, sir. Okay.
Sir, I have one question. Sir, what exact indices considered as a threshold after which we should go for the umbilical vein Doppler?
Okay, that's see, if you have all normal Doppler parameters, then it's fine. But this is essentially, it is a situation where you are fine, you're looking at something which you're not certain as to what to do. CP ratio is 1, fetal movements are less, fetus is 36, 37 weeks. You just add on one parameter more, and you look at the volume, you get a good volume flow, you're happy that the volume flow is good, and things are going well. Now I will give you a similar paradigm to if you're doing hepatic transplant. So if you're looking at situations like that, the surgeon in a hepatic transplant is always asking you, what is the volume flow going into the liver? What is they're asking you to measure the portal vein volume flow. So these are established criteria. Unfortunately, yet in the fetus, there are no established criteria. But I'm sure that will happen because it took time for us to look at CP ratio. It took time for us to move from umbilical artery to looking at uterine artery and other things. So probably more and more papers will get published. So I think it's just one more parameter that you can look at the moment. When you have a difficult situation, high risk pregnancy, you have a situation where you are already 35, 36 weeks, you can look at the volume flow. And if you feel that it's falling short of the cutoff, then you have the option of communicating that with your this thing. There are very few papers published at the moment. There are a handful of 3 or 4 papers that have been published on the subject. So that is the only criteria we have to go by.
Yeah, thanks, sir. One more question, please. Other than this Doppler parameters, what other things we must see in umbilical?
Yeah, so I would strongly suggest to look at the fetal heart, because the fetal heart is the area where we are seeing that in many of these growth restricted fetuses or high risk pregnancies, you may see the fetal heart and it looks normal. But when you actually start measuring all these parameters, you realize that what looks normal is actually not showing normal values. So it is, when you objectify these values, when you look at cardiac function, you come up with surprises, and you actually realize, and this is not only my experiences, on my personal communication with Gregory Bohr when he was in India, the first thing when we were discussing was that don't you look at the heart differently after you have started measuring the speckle tracking? And I said yes. Now I can even see the heart and see changes which I was not seeing earlier. So when you actually, magnify the heart, you take it to a frame rate of 70 and above, and then you do the speckle tracking, you can actually visualize subtle changes in the septum, on the way the septum is moving, on the way the myocardium is moving. And this is something you don't see when you're just looking at cardiac activity or when you're not zooming into the heart. So this happens. It's like, when you're measuring parameters, you don't miss them. You're measuring the tibia fibula, you're measuring humerus ulna. There's a good chance you may, while measuring, pick up an absent radius. And at other times, if you're not measuring it, then you will overlook it, and you will, you will feel the arm is normal. To something to that extent, that when we have started looking at speckle tracking, we have started to realize that there is more to the myocardium than just looking at the contractility of the heart.
Thanks.
Sir, just to interrupt, please. There's one more question from Dr. Pooja Mehra. How do we report the fibroscan values of the placenta?
Yeah. Again, it's experimental. There are a lot of papers already published, like we have published our paper, and you can look at our values. We took anything above 1.4 for a 90% sensitivity, and I'm not suggesting that you measure it and give it as a tool. You can look at high risk pregnancy situations. If you find the RP values are high, then you do your Dopplers, monitor these pregnancies closely, but don't make conclusive statements just on the RP value alone.
Okay. It's always the combined.
It's a combined. Nobody looks at only umbilical artery Doppler and manages the pregnancy. It's multi-vessel Doppler. So this is.
Yeah. So plus the values are actually having different units in different machines.
Yeah, but essentially we use meters per second.
Okay.
Or kPa, whatever.
Yeah, kPa is similar to, or there's a difference between the kPa and meter per second values.
See, we did our study in meters per second, but there are some studies which are also done in kPa. So you'll have to
my machine mentions kPa actually in elastography. So
which machine is that? Because most machines will give both measurements.
Yeah,
kPa
it gives
and
both actually. Because when I do liver elastography, I get it in kPa. So most of the time we are asked for liver elastography.
There are some reference values for kPa also.
Okay.
But I don't have it with me at the moment. But generally about 6-7 times meters per second. So 1 meter per second, it will be 7 to 8 kPa.
7 to kPa. Yeah. Okay, so Nitam sir, any other questions you have?
One more question, please. Sir, is there any significant correlation between the elasticity parameters and the indices of Doppler, like RI, PI, and S/D ratios?
That's a good question. I have not come across, but in our study, we did see the Dopplers. And as I showed you in one of the uterine artery Dopplers, but they were all preeclampsia patients. So they were expected to have high uterine artery PI. And there were 30 patients, 11 of them had IUGR, and a large percentage of them had high uterine artery Dopplers. So we actually selected fetuses with high uterine artery Doppler and then looked at the RFE values in those cases, vis-a-vis the normal cases which did not have Doppler and which had lower values of RFE. So it was a very selected population. So I don't think there's any correlation as to which is better. Of course, Doppler is an established tool. We cannot say that RFE will be better than Doppler, or it's a predictive tool. RFE can become a predictive tool, but Doppler, as I said in my conclusion slide also, Doppler is central to the management of IUGR.
One more question, sir. Is there any correlation between placental thickness and the elasticity parameters?
We did not look into the placental thickness, but I think that's also a good parameter to look into. We did not look into the thickness of the placenta. We, took an average 3 to 4 centimeter. We did not look at very bulky placentas or very thin placentas. We took the normal placentas. But that's a good question. I mean, there's something that needs to be seen.
Because I have read some article regarding this ARI in calculating elasticity parameters in placenta. They are telling that there is a significant correlation between the PI of uterine artery and the S/D value, which is a positive correlation with that maximum shear velocity and minimum shear velocity. So
yeah,
is it so?
No, there is a possibility. I mean, there are a lot of papers, but we did not look into the correlation. We just looked at already proven cases of FGR with Doppler changes. And we looked at, so we did not, do a blind study of both the situations.
Okay, so if we get a proven case of FGR, then only we should do for ARFI in.
It's an additional parameter.
Thank you, sir. Thank you, sir.
Nitam sir, Sudhir sir, any other questions to be asked?
Other than this Doppler study, what else we can look for? So any other pathologies?
You mean in high-risk pregnancy? Or?
No, in general.
Well, sky's the limit. You have a tool. You can look at, like I said, you can look at chorioangiomas. You can look at any situation. I mean, I'm now thinking of looking at the placenta with microvascular imaging, since now we have microvascular imaging and it's showing much better flow than power Doppler and Doppler. So I think it depends to be seen. You can probably use it maybe in CCAM or CPAMs or any kind of SOL. I don't know. I mean, you can probably use your imagination there.
Okay.
There's one more question from Dr. Ahmed Husman. Is placental grading have any relation with the fibroscan or any of the report?
Yeah, and actually we did not find any correlation, but I think I think we need to do some more studies, because sometimes we do see very heavily calcified placentas, and I'm sure that can be a potential cause for higher RP values. So that is also an area that we need to see.
Sir, what is the role of confined placental mosaicism in FGR?
That's a very, very big role. Confined placental mosaicism and uniparental disomy, chromosomal 16 abnormalities. I did not touch on that, but there is a huge incidence of IUGR due to confined placental mosaicism. At least, in the genetic portion, it will be, especially trisomy 16 and some other deletion disorders.
Nice.
So one more question. What are the genetic tests we are supposed to advise for a FGR baby?
Okay, that is also an interesting question. I would not suggest you to advise genetics for all FGR babies. First of all, you must select a very careful second trimester scan to look at all the soft markers and other markers. Now, if you have symmetric IUGR, I know that we used to use earlier the term symmetric and asymmetric, and people then started talking about the distinction not being so important. But if you've got a early onset symmetric IUGR, especially with normal or higher amount of LICA, then these are situations where I think you should do a genetic evaluation. Sometimes even if it's a consanguineous marriage, for example, or there is no other risk factor, like no evidence of uterine artery Doppler abnormality, or the placenta looks good, the LICA looks good, and then you have any other marker, like there's a spinal abnormality, or if there's all the long bones are short, and if maybe even the abdomen circumference is normal at times, then these are the situations which don't conform to placental cause of IUGR. So asymmetric placental cause of IUGR, which usually starts by about 25, 26 weeks and goes beyond. If you see IUGR at an earlier stage, if you've got recurrent IUGR, anything that doesn't match, there is no oligohydramnios, these are the situations where I would do a genetic evaluation, either a microarray or a clinical exome, depending on what we find. Nowadays, we usually go for a clinical exome, but maybe if you go stepwise, you go for a microarray and then go for a clinical exome. Now, in the last couple of cases which I showed you, they were completely out of the blue. And when we did clinical exome, we found syndromes which we hadn't heard of, like 3M syndrome. I probably must have heard, but never really seen. And we are actually seeing these pregnancies now. Or something like Rain syndrome.
Yes.
Very nice. Okay, so you had put up a last, I think one of the last slides of posterior urethral valve intrauterine fulguration of PUE. So, sir, how risky is what is the risk ratio of the procedure, and what are the outcomes? Meaning, how successful is it? If you suppose
that is just beginner's luck. We have just done one case. Vivek from Cochin in Amrita has done 2. And I think Suresh and Prashant have done a few cases. So these are I just put that because for me, that's a great, for us, it's a great achievement, because most of these fetuses we have always terminated. And it's just a great achievement. And in fact, it's an ongoing pregnancy. Tomorrow she's coming back for a scan. And I'm just so happy to see that we can treat. Essentially, Vivek from Amrita helped us a lot in that case. I mean, he's done 2 before, and this was his 3rd case. So these are new modalities, and I think it is a difficult procedure, not an easy procedure. You do need help from the obstetrician colleagues, people who have already been doing it. So you need mentoring, and your pediatric surgeons who can help you to identify the valve and fulgurate it. And there's always the fear, there are complications that are possible, like you can create a fistula with burning with the laser. And so we are very fortunate that our first case has gone well and is showing improvement. We were not really so hopeful, but believe me, more than us, the patient was insisting that you do anything to save the baby. And because of that, we went ahead. Otherwise, we were going to offer termination. So that is just initial success. Let's see whether you can replicate that. I'm not sure. And of course, more such convinced patients to allow us to do these procedures.
Because nowadays there are definitely many precious pregnancies, conceived after fertility treatment. There are many who come and we get this finding, and definitely as of now
there will be requests.
There will be a request. So definitely. So what is the timing of this procedure generally? Suppose we detect an anomaly scan.
We do. You can do it between 19 to 26 weeks. Because after 26, 28, the fetus becomes viable and you can treat ex utero. And really speaking, the main damage that is done is between 19 and 26, because the fetus lands up with severe oligohydramnios, renal dysfunction. So there's a lot of counseling that goes. Now, in one of our earlier patients, which we successfully put in a shunt, that child is today 17, 18 years of age, but now she needs a transplant. So you have to counsel. There's a lot of counseling that goes, that many of these may need a renal transplant. And this couple was, to our utter surprise, said, we don't mind. We will look for a fetal transplant. I mean, a renal transplant. So please go ahead. So I think that is a welcome change in the way our patients are thinking.
Okay, I think any other questions, Tushar, Sudhir sir, Nitam sir, or any of the viewers, or should we close this here?
Yeah, but I'm just remembering this. Dr. Chander Lulla taught us Doppler years back in 2000. You remember?
1991 we started.
and the things changed from that to 2020.
I think everything has to change.
Yeah.
And
but you are the one who always taught us about this
new things
very frequently. Yeah.
Okay, on Sunday, this Sunday at 10:30 in the morning, we are doing a webinar for GE on very new, exciting things that we are doing with the liver. So I suggest it's at 10:30 in the morning. New advances in liver elastography, and believe me, there are a lot of changes that are happening. So if you have the time, please do attend.
Yes, it's a very interesting topic. We get a lot of requests for liver elastography. I think now we should conclude.
Thank
you. And I really thank first of all Chander sir for giving such a excellent lecture. So many new things to learn. As always, we have learned always new things from you. And I would like to thank the Mindray team, because they have given us the platform to perform. Thank you so much, Team Mindray.
Thank you.
Thank you, Yusuf Bhai. Thank you, Bishop. Thank you, everyone from the Mindray team.
Thank you.
And thanks to all the organizers, Dr. Sudhir sir, Dr. Tushar, Dr. Nitam sir, and thanks to all the viewers for patientless listening and promoting the academic platform. So now I think I should conclude. Thank you all again. Thanks all.
Sir, from our side, thank you very much for this opportunity to get associated with you. Dr. Chander Lulla, as always, fantastic lecture. At this hour, 10 p.m. Mumbaikar is speaking. That means that shows a lot of energy and passion, isn't it?
Yeah.
So, Chhattisgarh IRI team, Dr. Harshad, Sudhir sir, Nitam sir, Dr. Mayor, thank you very much. We would like to continue this association with you. We can do, programs, more and more programs like this. As and when there is opportunity, kindly let us know.
Thank you very much, Harshad. Actually, Harshad put a lot of efforts. He
yes.
made an, a WhatsApp group and keep on informing, talking to the people. He did a lot of effort to bring this to this stand.
Actually, sir,
I think he'll continue to do so.
Yeah, definitely, sir. We will definitely do it, because I see we in radiologists are very low in number as compared to other branch people like gynecologists, because they have 3 or 4 times more number of seats than us. So definitely the numbers are more, but still I think there is a wave which has started, And I feel we will definitely have more and more webinars or conferences. And it's really wonderful to work with Mindray, I think, because they have been so supportive and so prompt. I think I have worked with other companies as well, but the prompt and the prompt support, and it was very nice actually. Vishwaroop, really thankful to you.
Thank you.
So the credit goes to Mr. Yusuf, our authorized
Yusuf
distributor
bhai,
in Raipur.
There's no say. No. I think all the Mindray people, not only one, but everybody has been really supportive, and I expect the same in future.
Thank you so much.
Certainly. We look forward,
Thanks
sir.
for
We look
giving us a
forward.
chance.
Thank you.
Thank you,
Okay,
sir.
thank you all.
Thank you so much.
Thank you,
Good night.
sir.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Good night.
Thank you so much. Good night.
Thank
Bye-bye.
you so much.
Thanks, Arnad, again.
Thank you, Sudhir sir.
Thank you, sir.
Bye-bye.
Thank you.
Nitam sir,
Thank you,
Nitam sir.
Yusuf.
Bye-bye. Bye. Thank you. Bye-bye.